Good morning, everyone. Thank you for joining us this morning and making this time with everyone's busy schedules. And this morning, we will have the majority of our meeting dedicated to Hicksney. We have many of you actually may know her, but Ruth Ann Craven, who has worked at AHI in the past and I guess all around the area and the region. She's working now with Hicksney and doing some great stuff. So she's going to share some of the latest and greatest items that can be very beneficial to the practices. I know when I sent out the agenda, I had mentioned we were going to be doing a Hicksney update, and we talked about it a little bit at the last meeting, but specifically asking you to think about how are you making out with your Hicksney? Is it integrated into your EHR? Have you seen those reports yet? And if you haven't, we're going to see those dashboards. We're getting a little background noise. Can everybody make sure they're muted if they're not needing to speak? So that's a bulk of what Ruth Ann's going to be talking about, as well as some of the quality metrics work that they have going on. Like I said, there's a lot of exciting stuff going on at Hicksney, and I'm not going to spend any more time talking so she can provide her information and we can all have a good discussion about it. I'm sure there'll be lots of questions. So I'm going to stop sharing and I'll turn it over to Ruth Ann. Ruth Ann, you're on mute. I see your lips moving.
Hi, everybody.
Good morning.
I'm trying to get to my slideshow. It's not letting me do this. Here we go. Okay. Good morning, everybody. Thanks for taking the time and inviting me to your meeting to talk about Hicksney. It's good to see a lot of familiar names. And everybody's camera shy this morning, but I'm Ruth Ann Craven. I'm the manager of programs and outreach at Hicksney. And I wanted to talk to you today about the role of quality data and how having quality data can help enhance the quality care that you provide at your practices. So we're going to preview some of the new things we have going on at Hicksney, and we'll open it up at the end for any questions that you have. So the first thing I wanted to talk about is our patient record snapshot, which was released in September, which if you are familiar with the Hicksney portal, it looks a whole lot better than what we used to have, which was very functional, but not very attractive. And the purpose of our snapshot is to give you actionable data at one glance. So you can see from the snapshot here, up in the upper left is kind of the demographic card. So it has the patient's basic information as well as their primary care provider, a little bit of information on allergies, smoking status, and patient contacts, as well as like their next of kin if you're having trouble contacting them. You can click on any of these options to get the full profile or to drill into any of the cards that you see here. Our quality indicators card is kind of like population health measures. So it would have any of the clinical quality measures. So this patient needs a colorectal cancer screening and breast cancer screening. You can also click into the quality indicators here, as well as the COVID-19 testing reports. Over on the right are documents. So you would see the most recent documents for the patient. So maybe you were interested in the discharge summary. You could click on that and go right to there. Medications are the most recently prescribed medications. Conditions are the most recent diagnoses. Procedures, again, are the most recent procedures, imaging tests, lab tests, and immunizations. And all of these are hyperlinks, so you can click right into the information. So we're going to go into this lab On the next slide, you can see what the lab report looks like. Any of the details you can print. You can either print them to paper or print them to a PDF to save in your electronic health record system. And you can also print that whole patient record snapshot into a summary report. So it's like a 3-page report. Some providers like to have that kind of in their EHR as kind of an overview of the patient's information. And this is all without sacrificing any of that detail that you've become accustomed to. So you have everything on the left that you've always had. So you can get into information prior to what you see here on the main screen. Okay. So any questions about that? And I cannot see chat. So if anyone's entering anything in
Ruth
chat.
Ann,
Yep.
I'm sorry. Ruth Ann, this is Sandy at Dr. Ryder's office. I've noticed that in the quality indicator section that that is not up to date. Is that something that is still in the works? Does somebody need to be sending something in order for that to be cleared out, or what actually is going on there now currently?
Yep, it is up to date in real time. It would only include patients that you have consent for. And I do know that Dr. Ryder's office, you've been having trouble sending us information. So because your information hasn't been getting to us, that could be why your office reports are delayed.
Okay, thank you. We're just noticing that there are colon screenings that have been done in the past that obviously didn't come from us, would have come from another provider, but they're not clicking off there for some reason. And we can even find it by clicking to a tab, we can find it, the screening, but it's not clicking off on the quality indicator.
Okay. You can send me an email with some examples if you have secure email, or you can give me a call with those examples. It could be how it's coded, and we can look into why they're not populating.
Okay, perfect. Thank you.
Any other questions? No? Okay. All right. So this really, yep, go ahead.
If people are seeing stuff along the lines of what Sandy's calling out, like things are not appearing as they're aware of, or they're not seeing the connections make, what is the best method to get that information to you all?
The best way is to contact our support department, which is support@hixney.org. Or you can call our main number, 518-640-0021, and that'll get you to support as well, because they're available and on the phones all the time. Or you can contact your account manager, but they're a little harder to reach.
So if they were to use the support@hixney.org, I'm guessing that's not a secured email, or is it?
That is not a secure email, but they can contact, and we can reach out to them via delivery slip, which is secure email, and they can respond to that with the patient information.
Okay, thank you. That's helpful information, because I would encourage, I myself have been in here since it's gone up and have also found out a few little things, this doesn't seem right, or they're not quite connecting. And I have sent the information in, and then they look into it and figure out what might be the gap of it. I mean, this is new. We all know with new things, they don't always go crystal clear smooth. And some of the connections might not be there. To Ruth Ann's point, maybe it's the coding issue. But I do try to encourage people, if they have a few minutes, at least to send to the support. And then, as Ruth Ann described, you'll get an email back where you can actually send the example and they can take a look at that. Thank you, Ruth Ann.
All right. So our quality reports, these are great for you to be closing your gaps in care. And there's 2 ways to get into the quality reports. One is from the patient record snapshot, that card that was in the upper right. You could click on that to get into the reports, or you can go from your portal account. you just go to the reports tab and you'll find the reports listed on the left-hand side of your screen. The quality reports are really into three categories. So first is the at-risk reports, which identify pre-diabetic patients or pre-hypertensive patients. Then we have gap list reports, which identify for various quality measures which patients are overdue for preventive care. So needing breast cancer screening, colorectal screening, or if they have hypertension and they need their blood pressure reading, cervical cancer screening, and then the diabetic nephropathy, diabetic retinopathy, and the A1C testing. And then the other group is the patients who are compliant. So we have an indicator that they've met that quality measure. And you can kind of look through that report as well. If you have received a report from the payer that says that patient doesn't have their breast cancer screening, you can actually go to our report and find out where they had it and get the documentation from that. Our eligibility criteria for these reports were designed by HCSCN, but they were informed by HEDIS, CMS, and the National Quality Foundation measures. So they should align very well with your performance incentive programs that the payers have for you. This is what a report looks like. Just one thing to note, only patients for which you have consent will appear on these reports. This is the mammography screening report. You can see that the patient, all their information here, last had this in 2018 at Albany Medical Center. So it can kind of point you to where to get those reports if you don't have them in your records. You also can overhear this hide. Is it like maybe you had a patient who you know had a mastectomy and is excluded from the measure? You can click on this to hide them so they don't always show up on your list if that's something you wanted to do. I know you're not supposed to have favorite reports, but actually my favorite report is the admissions report, which you can identify patients that might benefit from care management because it gives you your patients who have had ED visits in the last 6 months and inpatient visits in the last 6 months, and you can sort it by the number of visits. So we have some care managers who just, they prompt themselves every month to run that report, look at it, and just scan it quickly to see if there's anybody new that they weren't aware of that they might want to call to engage in care management. And we have quality measure reports, which allow providers to see at a glance what percentage of their patients are meeting the recommended standards of care. You'll see the ones in blue are active reports. So again, the diabetes reports, hypertension, and the cancer screening reports. The ones in gray are under development, and we will be adding them. So adult BMI assessment, COPD, childhood immunization status, and statin therapy for patients with high cholesterol. The quality measures, they look like these little gears to kind of show you out of the number of patients that qualify for the measure, which is the N, how many are controlled or uncontrolled for blood pressure, how many has had their mammography screening or needs the screening, and again with colorectal, and all of them say click here to view patients. So I clicked for the high blood pressure and then it brings up the report for you. So this patient, the last blood pressure was 140/92, so that's not controlled. Whereas the next patient on the list was under the 140/90, so that patient is controlled and meeting the measure. So that patient doesn't need screening and the first one does. So it gives you all that kind of detail, and it also has the last encounter. And that's important if you have someone whose blood pressure is not controlled and you haven't seen them at your office or you haven't seen them in more than a year. You might want to schedule an appointment with them to bring them in to have the screening done. And then in our additional reports section is where you'll find the COVID-19 testing reports. Again, it has the image and you click to view patients. It'll have the date the testing was done, where the testing was done, and the result. And it's kind of hidden over here, but we also have the antibody testing information on the right. At the bottom of the screen has the report guide. which you can look at the actual criteria that were used for each measure. And that's kind of important if you're trying to line this up with your different quality incentive programs that you have. You want to make sure that our criteria is matching the payer's criteria. And one thing I didn't show you was the comorbid indicators report. That will give you the list of patients who were excluded from any measure. So for example, pregnant women are excluded from the hypertension measure. A lot of measures have patients in hospice are excluded. So you might want to see who your patients that are in hospice are. Okay. So that's it for quality reports. Have you guys used the quality reports? Do you have any questions about how they work?
Ruth Ann, this is Jessica Schwartzman. How are you?
Good. How are you?
I'm doing very well. I had a couple of questions actually, because I'm not in HCSCNY on any sort of regular basis. But when you were showing the quality measure reports, and then you had the list of patients who either needed screening or didn't need screening, is that a sortable list? Are you able to, exclude the patients who do not need any additional follow-up and just focus on the list of patients who do?
Yep, absolutely. You can export any of these reports to Excel. And you can, like I said, hide the ones that you want to not show on the report if you wanted to.
Gotcha. But would you have to hide them individually by patient, or would you be able to just export it and then through Excel you can filter out the no's?
You can do it either way.
Okay. Okay.
I would probably.
And then, oh, go ahead.
I was going to say I'd probably do it in Excel because I'm most comfortable with that. So this little down arrow is to download it, and it'll bring you an Excel spreadsheet.
Gotcha. And the other question is on the patient side of things, because I know patients can log in and take a look at their own HCSCNY portal. Do they see any quality measures on their end? Are they able to see, that they need an additional blood pressure screening or they're due for their mammography?
The patient portal right now does not have quality indicators. It has just like basic information. So like they'd have their imaging reports in there, their lab tests in there, but it doesn't give them reminders of their preventive measures yet.
Gotcha. And then one last one, sorry. But with the COVID report, just to confirm, are those only your own practice's patients who have consented, just like the rest of the reports?
Yes. Yep.
Okay. Thank you. Thank you.
Anybody else? From my perspective, I know it's sometimes awkward to log into the HCSCNY portal to get these reports, but I think it's really valuable information. And if you set up a workflow, certain members of your team could benefit a lot from looking at these reports. I think the biggest benefit if you're working on closing your gaps in care, if you get all of your patients to consent, you will have one report on the HCSCNY portal for all of your patients, and you won't need to piece together your CDPHP report and your MVP report and your Fidelis report. It's kind of working one report. And I'm happy to help if you want, some ideas on how to fit it into your workflow. But it is valuable information for closing gaps in care, and it is very valuable for your care managers to identify people who might benefit from care management more proactively. Okay. So you can see there's a lot of information on all of the portal options that you have from HCSCNY. So one of the things that we're really focusing on this year is improving the quality of our data, because the old saying, garbage in, garbage out. We want to make sure that it's high quality data because you're relying on that to care for your patients. The American Health Information Management Association pointed out that if there is poor data quality, with health information exchange, it's kind of amplified because any erroneous or incomplete data is kind of filtered throughout the whole health system. So HCSCNY is very committed to improving the quality of our data. And part of that project came about because we were approached by CDPHP to apply to the National Committee for Quality Assurance to become what is referred to as a validated data aggregator, which is a pilot program that NCQA has launched. And we did find out last week that we are validated, which was very exciting news after 6 months of many long days. So we are validated, so health plans can use HCSNE data for their HEDIS reporting for measurement year 2020. So if you're contributing data to HCSNE, that means you could possibly have less requests for medical records because the data at HCSNE has already been pre-validated. One thing that we did find going through this process was an astounding 43% of our data sources passed with what's called omission. And what that means is there is a piece of data in the electronic health record system at the practice that was not received by HCSNE, which is a lot of opportunity for us to get more complete data to ensure that your gaps in care are more recognized when they are closed. So how do we improve data quality? So there's really 3 steps that we're working on. The first is referred to as primary source verification.
Ruth Ann, I'm sorry, this is Jackie. I just wanted to add something to that comment about the health plans being able to capture that data. We actually did sign with Blue Cross Blue Shield, Northeastern New York. They can get it, but we had to sign an agreement for them to be able to get that data. It's not automatic.
That's correct, with an individual health plan agreement. Let's go back here. But the National Committee for Quality Assurance Program, with their validated data, health plans can now use HCSNE information.
Even without the signed agreement?
Correct.
Okay.
But your facility in particular did not participate. Your data was not validated, so it would not apply to your organization.
And what makes that the data, how does a facility become validated?
Back in May, I had asked for medical records from all of our data contributors, and that was the process that NCQA used. Those medical records were used to confirm the data received by HCSNE matched the electronic health record system at the facility. And that is how NCQA decided which data sources were passed and approved and which ones were not. So out of we had 273 data sources. We were able to submit 243 of them. And out of the 243, 228 passed. So the ones that didn't submit were for various reasons, like your organization was going through an EHR conversion. You decided not to participate. There were other organizations that didn't have enough clinical data. So a lot of the community-based organizations or care management companies didn't have enough clinical data to meet the HEDIS requirements. And we also could not validate our substance use provider because there's a higher level of confidentiality with 42 CFR Part 2 requirements. So we couldn't do those either.
Can you send me who the contact was on that? Because I didn't hear anything about that. So it's just very interesting that nobody submitted data.
Actually, you were the contact. You said that your organization decided not to participate in the pilot per Patrice McMahon.
Okay.
I know there's a lot going on.
You.
Everybody's asking you for everything.
Ruth Ann, I have a question about that. So moving forward, if an organization chose not to participate in the pilot, then they're not eligible to work with their insurance and payers to submit?
Well, 2 things to that. If they didn't apply to NCQA this year, we do have a chance to revalidate next year. So moving forward, they can be validated and be included with the HCSNE reporting. For measurement year 2020, however, they would need to work separately with each health plan if they were not validated this year. Does that?
So, I don't know, let me ask another question. So if an organization did not participate in the pilot, they could still work with their health plans to be allowed to submit for their 2020 measures electronically?
They would work directly with their health plans like they always did before this pilot. So they would either be providing medical records to the health plans, or they could allow access to their system.
So they can't submit through HCSNE, is what you're saying?
Correct, not until next year when they get validated.
And so for an organization to be able to utilize this functionality, they themselves would have to be approved or validated that their data was meeting the requirements.
Correct. So the 228 of our data sources were approved.
And when you say data sources, are those organizations or are those actual data elements?
They're data feeds. So like a hospital would have a CCD and an HL7 validated separately, whereas a practice is usually just a CCD feed that comes into HCSNE.
So how many organizations were able to validate through this process?
I'm trying to do the math in my head. Got about 35 hospitals and facilities. So about a little under 200.
200 organizations. Okay.
Yeah.
And obviously the organizations would know who they are because you did contact them and obviously got that permission.
Yep, and we will be publishing it on our website as well. We're in the process of adding it to the data contribution report on our website. It will say what if they pass for HL7 or CCD.
Okay. And then moving forward for 2021, how would an organization be able to do this? Is there going to be a process or?
Yeah, it'll be much like the process that we had in May. We will need to revalidate with NCQA. So we will be asking every organization, all of our data sources, to provide us with one medical record, and we will submit that documentation to NCQA for our revalidation.
And if they've already been validated, do they have to be revalidated every year?
That is under discussion with NCQA right now. We hope not, but with all of the EHR conversions going on, whenever there's a change in EHR or a significant change or upgrade in system, they will need to revalidate, and all of our new data contributors will need to be validated each year.
Okay. And one last question then. And when do you think the time frame might be that you're going to ask? Is it going to be again in the spring?
I would say summer, because our validation is good for a year and we just got it in October. So I'm going to hopefully be optimistic. It'll be like, you know, the summertime.
Okay.
Because our process this year was kind of painful. It took like 6 months, but NCQA was building the plane while they were flying it, and they kept changing the rules and the requirements. So I'm hoping it'll be more streamlined for the revalidation.
Okay.
Okay. And I do thank everyone who provided medical records. And I appreciate all the cooperation with the back and forth with the auditors. It was really phenomenal, the amount of cooperation we got from everybody. So how do we improve data quality? So there's really 3 things. The first is primary source verification, which it essentially is just making sure that the EHR at the practice or the hospital is the single source of truth, and that the information in the EHR comes to HCSNE in either a CCD or an HL7 feed. And that information we received at HCSNE matches what's in the EHR. And then the third step is that we make sure what we display in our portal, or we send in an outbound CCD to the health plans, for example, matches what's in the EHR. So the EHR, the inbound data, and the outbound data all need to match. Okay. And what we are doing as a result of our NCQA validation, we are now implementing primary source verification for all of our new data contributors. And whenever there is a change in electronic health record system or a significant upgrade, and they're considered mock primary source verification reviews, where I review one record and kind of make sure everything matches. If it doesn't, I will circle back with you and meet with you. And explain to you what we did not receive or what was received differently from what was in your EHR. We can work on a workflow assessment, kind of thinking about in a typical office visit, who documents data, what data is documented, and where do you put it in your EHR to kind of find out if it needs to be in a different spot in order for us to receive it. And we have a little workflow that we can work with you on, and we have a data documentation grid to help you document where you record the key elements. And this also lists the kind of the data elements that NCQA is looking at, which is what you'd expect, diagnoses, procedures, patient information, provider of service, date of service, immunizations, labs, vital signs, smoking status, and allergies and medications are the big ones that they look at. So at HCSNE, we're doing this for all of our new data contributors, and whenever there's an EHR upgrade or any data source that we found an omission with when we applied to NCQA, or that failed when we applied to NCQA, I'm circling back with all of you now to review the findings and work with you on improving the data. But I'm also available if any of you want this done for your purposes. So for example, if you have a large organization with multiple locations, NCQA only looked at one record per data source. So if you have like 8 practices, you might want me to do a PSV for your other practices if they do things a little bit differently to make sure that the data is of the highest quality. And you might be thinking, how can I help? So the best thing you can do is make sure your providers are completely documenting and accurately recording all the services in your EHR system, and then cooperate with our efforts to confirm that the data we receive matches what's in your EHR. And if it doesn't, work with us in good faith to modify workflows or make corrections to make sure that the data is of the highest integrity that it can be. And probably most important, there's a lot of transition going on right now. So most important, keep your HCSNE account manager informed of any EHR upgrades or transitions, because we need to do an impact analysis of these changes. Whenever you change an EHR, the interface to HCSNE changes, and we need to make sure that's working and we're getting the data. And you're probably thinking, this seems like a lot of work. It is a lot of work, but there is some benefit to your practices. The primary benefit is you could probably receive higher clinical quality incentive dollars because your providers will be getting credit for all the care they provide, which will lead to improved performance on quality measures. There is less disruption to your practice if you are validating with HCSNE, because HCSNE will ask you for a record once a year, and then our data is pre-validated. So you won't be getting requests from CDPHP, MVP, Fidelis, all of them. And then we provide free performance improvement assistance and sharing of best practices with peers. So if someone else uses the same EHR as you and you're struggling with how to get it to work, we can connect you with other practices to help you out with those things. So does anybody have any questions about data quality and why HCSNE is focusing on that?
Hi, this is Tazeen from AHI. I have a question. In the previous slide, you mentioned that there might be cases where data submitted doesn't match with what they have in EHR. Why would there be those mismatches? Like, is it not being pulled automatically from their EHR systems? Just an example of what would happen in that process and why the mismatch occurs?
Yep. So the way the data flows from the EHR to HCSNE, in most cases, it's a CCD. I will say the majority of the problems that we had were omissions. So it was something that's in the EHR that did not get on the CCD and did not come to HCSNE. Trying to think. So probably one of the biggest things where things were missing were vital signs. And we're trying to figure out why. One of the practices I worked with, we found out that vital signs are documented on the vital sign screen when the patient is roomed, But then on the progress note, the clinician has to click on the vital signs section and pull those vital signs into the progress note in order for it to populate into the CCD. So if they skip that step in the progress note, it's not coming. Another example is with med-ent practices, if diagnoses are documented in the assessment section only, they're not getting to HCSNI. So they need to be either documented as an encounter diagnosis or they need to be on the problem list. So they're the types of things that we saw.
Okay, thank you. That makes sense.
And the NCQA auditors were very detail oriented. We did have one case that failed because the NCQA auditor disagreed with the diagnosis the doctor used. Although it was in the EHR, HCSNI received it, we displayed it, it was all correct from a data perspective. They failed that data source because they disagreed with the diagnosis.
Okay. Mhm.
Wow.
Thank you.
Ruth Ann, a couple other questions. Is it only through the CCD that they're doing the data validation? So if any other information comes from the organization into HCSNI, that's not getting scanned or looked at for this particular thing. It must be in the CCD?
The validation process only looked at what came in on the CCD or the HL7 feed. But as far as NCQA goes, once the data source is validated, any of that data can be used by the health plans.
Any other data besides the CCD can also be used?
Mm-hmm. Yep.
When you say HL7, I'm not sure I understand what you're saying differently.
Yep, an HL7 feed is kind of a real-time message feed, and the things that usually come through on that are things like diagnoses or lab results or a change in admission status. Those feeds come from hospitals and skilled nursing facilities, and they're kind of real-time quick hits. You'll see the HL7 feeds all got validated because they were really easy compared to a CCD, which is much more comprehensive.
So if somebody were to do a lab in an office, that comes over as a CCD or that comes over as the HL7?
Okay. In-office labs, if you're actually processing them in the office, they would come on the practice's CCD. But if you're just drawing a specimen and sending it out to a hospital lab, then the result would come on an HL7 from the hospital.
Okay.
Okay.
And then you had said something about immunizations on the patient dashboard, and here again, is it only coded immunizations that are getting counted? Because, you know, again, sometimes there is in progress notes that somebody got an immunization, but they didn't get it at the practice. So they don't have the actual claim, if you will. It's not getting coded by the practice as administered. So how does that get counted?
If the practice is actually documenting that the patient had their influenza last week at Price Chopper or whatever, that it would come in on the CCD. But if they just put it in free text on their progress note, it would not. So it really depends where they code it in their system. They can do patient-reported immunizations.
Okay.
Okay. And another thing, I don't know if everyone on the call knows, we do have an agreement with Price Chopper, so we are getting all of their medication and immunization data. And we also are getting LabCorp data from CDPHP patients. So does anybody else have any questions? I'm actually a minute over. Okay, so I am going to send Luann the data grid and the workflow assessment if you wanted to use that tool. And she also has my contact information, so any of you can contact me.
Yep.
Roxanne, one quick question. This is Lisa. I know you said this up at the top of your presentation, but as far as the practices are concerned, how current is the data that they can see in their portal?
Okay, all the portal information is updated in real time. And the way data comes to HCSNE really depends on your EHR system. So sometimes it's when the note is closed, it's sent. Other systems like hospital systems send it at midnight every day. So it really depends on how your EHR system is set up to send information to HCSNE, but our portal is updated in real time.
Okay, thank you.
Yep.
Good morning. Oh,
Yep.
Hi, this is Lisa Tuggle from Adirondack Health. I don't know about how other sites and hospital systems are feeling about this. Our compliance team is really struggling with allowing access to these insurance companies that are wanting to access our records and actually incentivize us, pay us to be able to do chart audits for these gap closures. You know, with the use of HCSNE, you're saying these payers will now have access to this information through HCSNE. I'm just wondering what kind of from a compliance standpoint, knowing that the patients consented to this, you know, that we're giving this information to the insurance companies where they have full access to the patient's history rather than just to the information that they need to close the gap.
Okay. I understand your concern. The state has really been pushing to have the NCQA validation program implemented. From a state perspective, as part of the Shiny, this is all part of the state's goals for moving forward. So I can understand your concern, though. Has anyone else, other organizations, expressed that concern as well?
this is Angie at Alice Hyde. UVM Health Network definitely has. So we're still waiting on even to get incentivized for a decision from compliance.
Okay. I appreciate and understand from your perspective, but the way the state's model works, the statewide health information network of New York, all of the data flows into the database regardless of the patient's consent. So the patient's consent to who can view and access their information, but it's all in that database.
This is Jackie. It's my understanding that if I'm hearing some of you right, as far as your concern regarding the insurance companies taking that data, is that to me, this is just a more efficient process for us as the organization, because the insurance company could essentially request records on 10 patients, and because you're contracted with them, you're required to submit that data. Rather, you have a plan in place to say that, you know, if they want 100 records, that they come on site to retrieve those records, they're still getting that information because they pay that patient's insurance. They pay for their health care. So there isn't anything that they're getting through HCSNE that they couldn't get otherwise if it was a manual process. So to me, which is why it did take me some to even get this one thing signed for Blue Cross, but that's just saving me time. And it's helping me close gaps by them being able to capture that data that I otherwise don't have to retrieve for them. And we're still getting the credit for it on our incentive program.
This is Angie. I made that argument multiple times, but I'm not, I don't know. It's above me. So, but I did make that argument.
But just, yeah. So either way, they're going to get it. And I agree with you. I did have to I've only had outreach from one insurance plan, which was Blue Cross, to do this. Yeah, it did take me some convincing, but I did get there. One is better than none.
Hi,
You know, I
this is
see the
Brenda.
benefit in it, and I agree wholeheartedly, and that's part of the argument that I've had with HIM and our compliance committee. It's, you know, I think their biggest concern is the fact that it's access to everything, and it's a little tighter for us to, or harder for us to control. Whereas if they're on site and doing a chart audit, or even if we're giving them the records, we're giving them specific information, whereas having access to the full, it's a little more difficult for us to lock down certain information in our EMR. So we're just having little, you know, challenges and trying to figure out, okay, what is the legal risk here, and what is our, you know, what should we be doing for our patients to protect their information?
So it's Brenda Stiles. Hey, Ruth Ann, nice to hear you again and see you. I think the big thing that we have to realize as we move forward, whether part of the ACO, not part of the ACO, and you know, to Jackie's point, as we move forward and looking at where CMS is going and where New York State is headed, they are being driven by the electronic clinical quality measurements. So there's a lot of different factors that are playing a part in this. So how we've been doing business in the past is really going to be changing. It's changing fairly quickly. And certainly, Ruth Ann, if you want to chime in, you can as well. But I think we have to start thinking a little bit differently. And certainly this is great feedback. Angie, I was not aware of that. So certainly those are some conversations that we will need to have, because we look at the duplication of efforts. You're closing gaps daily in the office. This information is being sent. And I'm just going to throw out there, Excelis and the Empire Anthem plan do not accept supplemental data. So without them accepting supplemental data, and as in the North Country, we see people changing insurance, you know, fairly regularly. Gaps that you've closed and are long-term gaps that, you know, just colorectal cancer screening, you're not going to have. And it's been a struggle, you know, from our standpoint to be able to, you know, work with the payers and trying to help them understand and work with them to close gaps. Certainly Blue Shield, Northeastern New York, TDPHP are being really proactive, because it just decreases the burden all the way around on the providers as well as the payers end as well. So, and with CMS this year, for 2021, what they are proposing as far as for the Medicare savings program, and really with the MIPS reporting, that independent practices that have to report, they are looking, you know, certainly looking at utilizing a data aggregator to submit for 2021. So, you know, there's a lot of moving parts and a lot of things that are changing. And so, you know, the more feedback that we have about some of those struggles, certainly that's information that I need to take back. So thank you.
All right, guys, thank you so much.
I just had one more thing to add. For anybody that's part of MIPS and taking, submitting data for that as well, anything that goes through HCSNY and that's able to be captured in that manner to help add to showing the quality measures that are from HEDIS on a HEDIS side, all those things that you're able to show them that are being done that maybe they otherwise wouldn't have captured is all to your benefit.
Thanks, Jess.
Okay, any other comments or feedback? In your slide deck that I provided today are the slides that Jackie shared, so you'll get all of those. And then, like Jackie said, she'll send the workflow information and documentation grid, so we can also share that with you. And with that, I'm going to go ahead for our last few minutes. I did send out a brief survey just to kind of touch base with all the practices to see how everyone is doing and does anyone specifically need any help. I appreciate everyone taking the time to complete the survey. We did have 7 organizations respond. 60% of them have submitted for their annual recognition already, so congratulations to those. And 75% are prepared to submit. So many of you are already on your way to submission. Again, I'll just remind you, 11:30 is the cutoff date. If you were due anytime between April and November. And even those that we do in December would still be 11:30. It's those that come up in January, and there are several of you, or a couple of you maybe, that might be in that boat, but just to remind you of that. There was 37% that said they could use some assistance. Some of you gave very specifics and others were a little bit more general. I'm gonna, say again, if you want to reach out to myself and or Brenda and let us know what kind of assistance you need. We do have some folks that can help with just even reviewing your tracker or reviewing whatever you think needs to be reviewed before you're ready to submit it. Any questions or comments about the PCMH being ready to submit, tracker grids, difficulties? Okay. There was a couple other questions we had spoke about and kind of in preparation for next month's meeting. And I'm glad, Jackie, you raised the thing about the MIPS measures, but we had asked if you're pulling your quality reports out of your EMR, and we do have 75% that are using their EMRs to actually pull those reports. And again, if people need help or are looking for some support in any of the EMRs, we do have some, help that we can assist with. Certainly, it's the EMR itself that you are going to have to work with, but we might have some helpful hints or suggestions, or there's other partners that have already been through that. I will say that I did get a notification from MedEnt that they're going to try to start up those user groups. I know many of you are using MedEnt at this time, so I'm hoping that they'll get started up here soon so people might be able to further utilize the MedEnt reporting, and if we're struggling with that, again, understanding how we can improve it. As well as we asked about the MIPS, and people have turned on, about 50% said that they have turned on their MIPS measures. And to Jackie's point, it is very beneficial if you can do that. Again, if you're looking for some assistance, we can certainly work with folks to see if we can help. Comments or questions about any of that? Okay. Some NCQA and QPAS updates. Just a reminder, this weekend they are updating QPAS again. There definitely has been some glitches. We did get, and I'm going to ask Jessica Schwartzman just to give a few minutes on this as we wind down to the end of our meeting. But this came from a quote that she provided, and I think it was worth repeating for people so that they have some information about some of the challenges.
Thank you, Luann. Yes. So we've seen some practices that are having some difficulty submitting this year because when they go into QPAS, they're seeing their data from last year, and the criteria is locked and marked as met. So there's some glitches on that end. We're also seeing some practices where the criteria is not marked as met, but it is locked still. So we've received some feedback from NCQA. If this is happening to you, the first person I spoke with at NCQA said, well, if you can just click new and submit new evidence. The most recent update on the forum said that if you're seeing issues like this, please submit a request with your site name and an explanation of what you're seeing so that they can work with you directly to set the whole submission up correctly so that you have sort of a clean slate to work with. So the bottom line is we are seeing a number of glitches this year in QPass. I am not confident that the update that we're taking this weekend is necessarily going to resolve all of them. So if you do see issues as you go in, or you're noticing that last year's submission data is linked to your criteria for this year, throw a ticket out to NCQA, let them know what's going on, because then they can help you get your submission set up correctly so that you can go ahead and submit with your new data. Sandy just sent a question, do we submit requests with our NCQA assigned person? Yes, so you can, there's two ways to submit a ticket. Either should be fine. You can either do it through QPass, which will have you select your site, and we'll send that ticket directly to your QPass representative. Or you can just log into myncqa.org and then you can start a ticket that way. But if you do it that way, just make sure to include your practice site name. So a couple ways to do it, but either way, it'll get to the right person on their end and somebody will reach out to you and help. I would advocate for working directly with your QPass representative because that's what they're for. As far as the upgrade goes, we are taking an upgrade to QPass October 16th through 19th. It should be available on the 19th. You most likely won't be able to do any work in the system while the upgrade is taking place. This upgrade, there's going to be some screen changes. The goal is that there's going to be a pre and post snapshot view for your check-ins, where you're going to be able to see, what you're submitting for in your check-in very easily. And then afterwards, you're going to be able to see a review of, what you submitted and what the outcome was. There's also going to be some changes for your primary contact screens so that you can see all of that information, the primary contacts for each health center on one screen. And the other thing that I did want to mention is that moving forward for your virtual check-ins, NCQA is switching from Skype to Zoom. So if you end up with a new practice that you're onboarding and you need to go through this process with the 3 check-ins, you will be using Zoom. I'm assuming they're also going to use that for any virtual audits that they need as well. So they are planning some big changes there. They are hosting 2 Q&A sessions to talk about all of the changes on October 22nd and again on November 5th. I am planning to attend the October 22nd session, and if anything comes to light that we didn't discuss today, I will send a summary.
Thank you very much. We are at the top of the hour. I do understand people have hard stops, so by all means, I'm just going to mention to you for the November topic, we're going to continue to do some talking around reporting and coding, and if there is specific questions, we'll send out some questions ahead of time and see if we can't gather some of that information. Brenda, do you have anything else to add before we sign off? Nope. She might have had to jump. Additionally, we do have our website, the recordings and the slides from the meetings are put up there as well. So you should be able to follow up with that, as well as anybody that wasn't able to make it, they'll get this information. And I wish everybody a great day, and we'll talk to you soon.
Thank you. Bye.
Thank you, everyone. Bye.
Thank you.